Thank you for joining us today for SBIRT in Action Accelerator for Healthcare Integration. The presenter today is Les Sperling, who serves as the Chief Executive Officer of the Central Kansas Foundation. He is a licensed addiction counselor and a child custody mediator, and he's got over 28 years of experience in the field. Les, I'll turn this over to you now.
Thank you very much, Christine. Good day to everyone, and thanks to the ATTC for this opportunity to share some experiences with you. The perspective I'm going to bring today is of a very small, not-for-profit substance use disorder specialty program that over the last few years has been trying to find a path for success in the future within the context of healthcare reform and what role we will have to play. We do serve the entire state of Kansas. We have a fairly robust continuum of care that includes detoxification services, medication-assisted withdrawal, and outpatient services, as well as prevention services and education programs. As we started thinking about where we were headed and what role SBIRT would play in our efforts to integrate, we took maybe just a little different approach in that, one, we don't have and have not received any grant dollars to do the work that I'm going to talk about today. That is not because we don't value grant dollars. It's a reality that in the state of Kansas, we just don't have very many federal dollars flowing in. The other approach was that we really believed we had very valuable expertise to market to medical professionals in acute and primary care setting, and that we believed we could prove that when we applied that expertise that patient health would improve, and as I'll talk about later, that healthcare costs are reduced, obviously, when chronic illness is managed effectively and when early intervention is applied. And our whole strategy has been to be compensated for the work we do within the healthcare marketplace. And we've had some success at that. The future is unknown, as you all know, but we are hoping that building that foundation and moving from fee-for-service to value-based risk-sharing propositions will create a path for us to move forward. Our goals were fairly simple. Most of you, I'm sure, from looking at the attendee list, are involved in many different levels as we are. But our main focus was around health homes and bringing SBIRT to primary and acute care settings. And one of our main really good things that gave us the ability to do that was in the acute care setting to look at the high costs associated with alcohol and drug use and misuse and addiction. It was also by completing this integration to improve access to primary health care and oral health care for the patients that we serve. We do a significant amount of work on the federal block grant, and so those patients, as you all know, do not have routine access. Kansas did not expand Medicaid as part of the ACA, so we're still advocating for that. And then obviously the full integration of our services into primary and acute care settings. Again, our approach was not so much to teach or have medical professionals learn SBIRT, but to allow us to bring that expertise into that setting and work with them. And I'll share with you a few of the outcomes that came from there. I'm going to begin with just some work in the acute care settings because as I listen and read a lot of things, I don't hear a lot of people talking about what we believe is a tremendous opportunity in acute care. This is a small regional health center in the very center of Kansas. We serve a large area, and with 27,000 ED presentations per year, alcohol and drug admissions into the ED were the second most frequent readmissions in our community and in this population. So there was a significant need identified both by the acute care setting and by us. The services we initially contracted to provide, we do provide the 24/7 coverage of the ED, and one of the most exciting things has been the full-time SUD staff on the medical surgical floors. We began just by being there to provide assistance, and it has matured to where our SUD personnel do rounds with the hospitalists to visit patients. Interesting statistics from our small market. This hospital actually only had about 250 admissions into hospital beds per year for acute alcohol or drug withdrawal. But when we began to look at secondary diagnosis, that number grew to 2,900 admissions a year. So I think you can see with SBIRT and the presence of pre-screening and screening and the whole process, what a tremendous increase in business and in treatment as well that was generated from our work. A key ingredient for the services that we provided is a warm handoff to all the substance use and mental health services that we recommend or that the team decides to recommend. This was a difficult thing to do, but it has resulted in, on that other side, that 58% of patients recommended for further intervention have made their first 2 appointments. To me, that's a low number, but when I look at other numbers in our organization as far as attendance, that's not bad, starting from basically a cold call in a hospital and having that level of patient interaction and engagement is a good thing. We were able to move, by having that staff in the emergency room, that readmission number completely off the list, so it's off the top 25. We reduced the length of stay significantly. They were experiencing length of stay in the range of 6 to 8 days. The vast majority of those are 3 days or less. The longer stays are obviously related to comorbidity and significant illness. We triage or screen patients in the ED, and that's a high number that are not admitted to the hospital. We do have the benefit of, obviously, in this community, having beds available to step those people down. If there's not a real serious medical issue, we can move them into our detoxification program. And another interesting outcome that the hospital has been very, very pleased with is a significant reduction in adverse patient and staff incidences related to intoxicated patients on the property. It's been reduced by 60%. Risk management folks tell us that our presence there and our ability to manage these difficult patients has really improved that outcome. Obviously, in the first year, we were swamped with detoxification admissions as part of this process, and the good thing is the 300% increase in commercial insurance reimbursement. I do need to caution, we had a very low insurance penetration into that market, so that number moved to, for our organization, only 26 admissions per year prior to this activity, now up to about 150 or 60 this year. Which results really in about $500,000 in additional income for our $5 million budget organization. But we actually began with SBIRT in the primary care setting. We are fortunate in this community, again, to have 13 family medicine residents in our federally qualified health center or program. So we are integrating with them and are doing the full SBIRT process with the pre-screen and screening and brief intervention with staff on site for 10,000 unique patients a year. When we began our discussions with this group, their data showed that 4 to 5% of their patients had an alcohol or drug problem. After 1 year of SBIRT, we're showing a 23% So they were rather shocked by that. Our process is we have SUD staff on site in the primary medical setting, and it's a unique to us. They need to be able to be interrupted. They are available in real time to respond to a physician's request for consult, and I'll talk a little bit later about our experience selecting that staff and how important that was. While I said earlier that we were not really focused on training medical practitioners to deliver SBIRT, by virtue of us being in this primary healthcare setting and the physicians and practitioners seeing their patients improve as a result of our intervention, obviously their interest peaked. And so we were able, with the family medicine residents and faculty, to actually capture them for 4 hours training on SBIRT and motivational interviewing and really teaching them about what we do, there have been some practitioners whose interest is high, and they are beginning to even move further with their integration and utilization of these principles in their practice. The other thing was co-location was part of this, and we do provide for their patients on-site level 1 and level 2 outpatient services. The census has grown since I did this slide. We maintain about 15 to 16 in those services. And of course, that is a very elegant situation where a patient may see their physician be screened as positive and then be able to just engage in treatment that day or the next if needed at the same location. Obviously, the benefits of being in the primary care practice as touch points throughout the year with the patients that we screen. Those that don't follow up, we're available there to assist them. The other really exciting thing for this FQHC, they did receive their level 3, the highest person-centered medical home accreditation. And if I can paint a picture of how our staff operate there, we really have become a key partner in the staff. We hang out in the pods, we attend staffings, we review patient care, and it's been very, very successful. We did have some difficulty. Obviously, our learning curve on the medical culture that is so different from our SUD culture that it took a lot of training, a lot of interviewing of employees to find the right person that could adapt to a very fast-paced medical setting, a professional setting, and we had some interesting lesson learned around that, and one of those is when we train people now to go into these settings, both the acute care and the primary care, we let them know right away that they really only get one bite out of the apple. If practitioners have a negative experience with the screening or with the brief intervention or with our knowledge base or our ability to solve problems, it's been our experience, that's not their job to train us to do our job, and if we don't do a good job, they'll turn elsewhere for that service. I do want to mention in particular our use of recovery coaches and peer mentors in both the primary and acute care settings. They have been incredibly important. We use them in a number of services. Immediately when someone is admitted to the hospital, we provide discharge planning from day one, and peer mentors are a part of that. They may engage the family. They may actually even just sit with the patient during the course of their medical detoxification for periods of time, and they have been incredibly valuable to our efforts. Just wanted to share with you a little bit of our timeline, and because those of you that have been pursuing integration will understand this very easily. We really began in 2009, and there's this big gap from 2009 to 2010, and really what that was, I spent every evening reading CMS circulars, trying to understand the external and internal constraints that face primary health care clinics and understand their reimbursement, and also hospitals. So those of you that are familiar with CMS circulars know that I fell asleep really fast, and it took me a long time to read all those. But there was a great deal of preparation. Another lesson learned that you'll see is that our experience was to expect long delays. Obviously, medical settings are very busy, and if it isn't related directly to patient care, it may be days, weeks, or months before you hear back about some of those collaboration things. What we were able to do in 2010 is really look at the data at each of those settings, the reimbursement analysis, and very critical was the workflow mapping, a formal process that just how is this going to work, how are we going to do SBIRT, who's going to do what when, and how will this integration piece work. And there were, of course, a number of other very high-level barriers. In 2011, we were able to successfully execute an agreement with the Federally Qualified Health Center. We hired the staff, trained them, and got them on board with the SBIRT process. In this particular area, the med techs do the initial ATTC pre-screen in the rooming exercise, and if it is a positive screen, our staff receive a text on their cell phone, and then they coordinate with the primary care practitioner about how and when to intervene and have that discussion and complete a full audit screen. And this is really a fluid process. It depends on the practitioner. Sometimes we're brought in office at the end of the appointment. Sometimes we're brought in early. That's the flexibility that we had to develop to be able to do that. It's not uncommon for our SUD staff therapists to be in an individual counseling session and to have a knock on the door or a text received. And so it took, again, some training and work to be able to work out that process. We were able to do the co-location, and we began doing the universal screens. We kept a good data set at the FQHC. I believe it's their UB4 data, those kind of things. We worked all those issues out. Of course, other issues we had to go over were confidentiality, EMRs, EHRs, all those things, high-level barriers. The planning for the level 1 and level 2 services and the co-location was a separate step and took a lot more. And I think, obviously, as I've said, one of the benefits was SUD staff really participating in all the clinical staffings and patient treatment planning. In the same year, in 2011, we executed a contract with the acute care hospital. They do pay us to provide the work that we do and put those staff in their facility. In 2012, we were able to complete the on-site level 1 and level 2 services at the FQHC. This has not been without difficulty. I think those of you that work in medical settings, when you consider doing group therapy with persons diagnosed with substance use disorder, we have had some adverse incidents. We've had to resolve those. We've had to define what space can and cannot be used. And that is an ongoing process where if patient behavior becomes problematic, it is incumbent, obviously, upon us to take care of that. There is still stigma attached to the persons that we serve, so it's not unusual if something goes wrong for us to be the first one to be blamed. So it does take some administrative work to conquer that. We review our SBIRT screening data frequently, quarterly, and we did adjust some workflows. One of the things that changed was that initially the FQHC wanted people screened at every appointment. We did not think that was a good idea, that there would be some patient fatigue, and that's exactly what we found out. Patient feedback was, why are you asking me these questions every time I come to see the doctor? So we have gone to an annual screening, and of course that adjusted the volume of work in some cases and the workflow itself. I mentioned we were able to provide the brief intervention training, and it is, of course, very rewarding to see that knowledge start to be integrated in the practitioners and in their practice. The strategic discussions really related to program expansion and the establishment of clinic at SUD locations. This is just the bidirectional integration. We are currently still in those discussions, but the plans are moving forward to do clinic at our facility as well as clinic in our local community mental health center. There's been good collaboration there. Obviously, I'm very excited about that because the need for primary health care in my patient population is significant. And as the FQHC also has dental care available, we are really excited about that. We have many barriers to discuss still across reimbursement because we have so many, as you know, reimbursement streams, and getting through those barriers is significant. Our FQHC was awarded a grant to expand behavioral health care. That was actually a bricks and mortar grant that they built additional space for us to be in. That is about completed, and so when that's complete, the Community Mental Health Center will have mental health staff there, and we will have our SUD staff in same space working together as part of their person-centered medical home. We had a great success in 2012. Our SBIRT codes, which I will show you later what the reimbursement rate is, were approved in the state Medicaid plan. They are, of course, in most insurance plans as the ACA moves forward. We were not able to get the codes active on the block grant yet. And I will mention that this took incredible advocacy. If you ask my single state authority for substance abuse about my behavior for the 2 years prior to 2012, she will tell you that I never said hello. I didn't say, how are your kids? I said SBIRT codes at every opportunity. And we were fortunate to have some champions to get those codes in. I'll just mention the entrepreneurial aspect of what we did. We had no funding whatsoever to support the staff that we placed in the FQHC. To begin with, we were just hoping that we would be successful in generating treatment referrals to support the staff, which we were, and also successful in our efforts to get SBIRT codes, and we're happy that those are now in place. The integration of patient health information and medical records has been significant. I will just, in the beginning we just made a note to file about our work, and we have actually engaged both electronic medical record vendors. We have different vendors. One of the requirements of the person-centered medical home is to report our data to the Health Information Network. So we're actively pursuing that, and that remains a costly and difficult process. We have been able to resolve the CFR 42 issues and move forward with that. So it is a little more seamless in our care and our documentation, but there are still issues to resolve. And the thing I'm most excited about, our little town of 50,000, the health center and the FQHC are actively engaged in recruiting an addictionologist to our community. Throughout this work, the decision has been made that there is enough work here for an addictionologist between the hospital and the primary care and our facility. I used to ask our recruiter every week how we were doing, and she finally told me, you might want to ask me twice a year. Obviously, there aren't very many addictionologists. Advocacy, I hope, there are increases in the number of programs being developed in medical schools. And so I will add, while I have you all on the phone, if you know an addictionologist that loves the plains in Kansas, please give them my name and number. This is what we were able to achieve on the SBIRT codes in Kansas. I will add that they became effective the 1st of 2013. We have yet to have them implemented. We were all set for go live December 9th. We have managed care for Medicaid. 3 managed care organizations do that in our state, and as they were going through the process, I'm not sure what issues came up. I have been assured that those will be live for us soon, but we've yet to be able to capitalize on them. However, we will be able to receive reimbursement for all those services documented back to January of 13. The exciting thing that we believe we accomplished in Kansas is that we have a large provider panel for SBIRT that includes licensed addiction counselors and health educators, health coaches. We have a behavioral sciences regulatory board that licenses all the discipline, and so if you have that license and receive the appropriate training, you are eligible to provide SBIRT. In Kansas, substance use disorder providers can do SBIRT activities in their facilities. So we'll see how that goes. So the $24 per 15 minutes capped at 4 hours is what we have. And we are just looking forward to being able to capture that, and glad that we have the panel that we have. I'm moving much faster than I normally do, so I may not be keeping you too long. We had a lot of lessons learned. Again, researching the external and internal constraints were critical. It took a long time to understand the encounter rates, and I still don't know that I understand hospital-based reimbursement, but we're a little bit better with that. I should mention that we are not just in this one hospital anymore. We have expanded these services a great deal and are currently in conversations with several hospitals in Kansas and Oklahoma and several medical practices. I really believe this is a great opportunity for all SUD people. There's not a acute care facility in the nation that does not have this problem, and they're certainly starting to pay more attention to it. When I go talk to hospitals in the initial conversations, my first conversations are not with CEOs. They are with ED nurse managers and ED physicians. And this is a blunt statement, but to a large degree, our ability to manage those highly intoxicated patients in an emergency setting and, frankly, get them out the door and somewhere else quickly is, of course, of great service to those facilities. And our ability to do that has opened the door to then begin universal screening and integrate that. I will add that in our experience, just beginning with universal screening in acute care settings has not been successful. It comes after we're able to manage those chronically ill patients in a better way, in a more cost-effective way. But obviously, you do have to develop a champion. These conversations are lengthy, as you know, and are lots of pitfalls, but I think if the focus can remain on improving patient care and lower costs, you can be successful. We use a lot of data. We have all the CPT codes related to alcohol and drug abuse, as well as all the DRG information. When we visit with an acute care facility, we request a look at that data, and also, as I mentioned, with the UB4 at the federally qualified health centers. I will add we are beginning to work also with freestanding primary care clinics, but our experience has been in Kansas, at any rate, that those are becoming rare as they are being purchased by hospitals, and we don't anticipate that changing as the healthcare marketplace changes. But that data is very helpful to demonstrate the impact of substance use on overall health and the costs in the patient care. We decided early on that we are the go-to people. It is a customer service perspective that we will do the work. that requires a lot of administrative time and problem solving. That was critical when working with credentialing at the facilities. We have many masters, as I mentioned. We had to complete credentialing with all MCOs, and we did all that work, filling out the paperwork, plopping it on their desk to sign and going through that. And it took a lot of time, but we believe that was to our benefit, to be that go-to person for that kind of work that nobody likes to do. Again, our experience has been it took twice as long to get things done as we wanted to. I don't believe that's still the case. I think SBIRT is growing, at least in the state of Kansas, certainly because of the reimbursement, but we are also looking at every health department and schools. I have a meeting right after this one with the school district to look at implementing SBIRT in the schools next school year, screening ninth graders. That's the starting point. So I'm hopeful that those who are starting now to look at this and develop this expertise will have a much easier path to operating and getting the program going. The other risk I would mention here, just honestly, is that as revenue starts to show up for the services that we provide, medical practices and acute care settings are asking appropriately, well, can we do this? And I'm not sure how that's going to play out. Right now, we're still committed to being that expert that brings it in, but for instance, our regional health center is interested in asking for information about placing 10 beds in their facility to do detoxification. So just a heads up on some of that. I can't overemphasize the customer service aspect that we try to promote, and that is a learning curve for all our staff not to waste busy medical practitioners' time. If I can accomplish what I want to do in 3 minutes, I'm a lot better off than if I take 10 or 20 minutes. And we place their requests from the medical settings. We do our own triage in a sense, and their requests are always on the top. They're worked first, no matter what. And then we continue to focus our efforts on educating a lot of people about addiction as a chronic illness and moving that conversation forward to address the stigma and everything else. Cost-benefit data has been incredibly important in both settings. Obviously, if you can reduce through SBIRT and intervention and staff in an acute care hospital the charges and length of stay related to a particular DRG, that is very beneficial to all concerned. And our trend data over that 5 years is good. We are able to do that. And so that obviously drops right to the bottom line for the acute care facility. And I think on the primary care side, those outcomes cost-wise are much more difficult to ascertain. But on the other hand, the outcomes related to patient health improving, coming back to their doctors saying, I cut back my drinking, I stopped my drinking, I no longer need the prescription for pain medication, those kind of things have been more important. And it really is a difference that I'm sure you're aware in the strategy to approaching the initial conversation. With our primary care practices, it is about patient care. In the acute care facilities, cost savings and those kind of things are a prominent feature of the discussion. We did bring the promise of SBIRT reimbursement to the conversations and also the possibility of some additional grants. We have gotten a few small grants, but the biggest advantage obviously was the successful implementation of the billing codes for SBIRT. We partner for our mental health services, although we do have clinicians on board, mental health clinicians, but in our particular area and situation, our relationship and collaboration with the community mental health centers is a real plus, and we use their staff together to form that team that has the impact. But we do have to do in the future a better job of building mental health services capacity. One of our issues is psychiatric time, and 40% of the patients that we see are co-occurring. So building that capacity is certainly a significant challenge and something we continue to do. I know we're a very small program in the middle of a rural state, but I believe on the acute side and the primary care side that SBIRT, that what we're doing is scalable, and then any program that has SUD expertise has these opportunities available to them, even more so as the penalties for readmission and those factors come into play into healthcare finance. As I mentioned early on, our desire is to survive and to thrive in this new environment. And as we begin to move to risk-based reimbursement, obviously it's very important for SUD providers to know their costs, to be accurate about that, and be knowledgeable about being able to contract in some of these complicated contractual negotiations. That's a learning curve for us. We're getting better at it, but as a small organization and many other small organizations around the state in our same situation and region may have some difficulty with that as they move forward. So to build that capacity, we believe, is very important. The other thing I'll mention is that we have begun using a smartphone app. It's called CHESS, C-H-E-S-S, developed out of the University of Wisconsin-Madison Center for Health Education System Studies, I think, that we're very excited about. It's a phone app that supports people in recovery based on self-determination theory and cognitive behavioral theory, has a panic button where people can immediately access a clinician or a support service, and a host of other features that we are planning to integrate this year into those subgroups or cohorts that come from the acute care facility and the primary care facility. So we're anxious to see what the outcomes are there. Gee, Christine, I went really, really fast. I'm sure I left out a lot. But
oh, don't say that, please. Yeah, I would like to insert a couple poll questions right here, though,
sure.
So we know where this audience is from. So if you don't mind, we'll keep your contact information up, but let me get these poll questions out of the way, okay?
Okay.
Okay. So this is the first one that we would like people to fill out. What is your current professional role? Choose either counselor, therapist, social worker, or case manager, nurse, nurse practitioner, physician or physician assistant, program or unit administrator, university student or faculty, or other. And if you would like us to know what that other is, just type it in the questions box or the chat panel, and we'll keep track of that in our records. Okay, it looks like we have a pretty good representation right here. I will share the results. In the first poll, 29% are in the counselors or social workers. 4% are nurse, nurse practitioner, physician, or physician assistant. 32% are program or unit administrators. 7% university student or faculty, and 29% other. So I have other, there's a government worker, a clinical researcher for a psychologist, and a purveyor of EBP, help programs implement evidence-based treatments. So those are some of the other roles that people have here. Okay, I am going to the second poll now. Okay, here's another one. What field do you represent? Are you from mental health, addictions, physical health, education, or EAP? Okay, and I will now close this poll and share it. We have 7% from the mental health field, 78% from addictions, 7% physical health, 7% education. Thank you. And now these are going to be two real short ones. Here you go. Do you currently conduct SBIRT interventions? Yes or no? Okay, thank you. Okay, so basically just over 2/3 do not do SBIRT at this time, and 1/3 does. So it's 32% yes and 68% no. And we have one more. Does your agency currently use SBIRT, or do you expect them to be moving towards SBIRT in the future? Okay, thank you very much. We'll share this one now. Even though about 1/3 of you just actually do SBIRT now, 77% show that their agencies are either doing SBIRT or will be doing it in the future, and 23% say no. So thank you very much for that. That really gives us an idea into our audience here. So let me just get that poll one, hide that one then, and Les, we will go back to your contact information that we're showing now. Now, Les has completed his information, and we would like to know your experiences with it, if it's something new in your organization or your hospital or your clinic, and how is it working for you? So if you could just take a couple minutes to let us know that, we could start a conversation in this. Or if you have any questions to ask Les. And Les, I do have a question that just came in. Les, how do you work out the interruptions to therapy with patients and clients being interrupted? And where are the training expectations for people conducting SBIRT?
Really good question. It has to be starting from the beginning at every level of the primary care practice. We let patients know up front that in this practice, your doctor's appointment or therapy appointment may be interrupted because we have situations that come up. It's in paperwork. It's also just reinforced throughout the organization that this is how we do things here, because some people's needs are emergent and we have to drop what we're doing. So a therapist will, one of the first things that, at the first session, will inform their patient that, hey, there's a chance that we may be interrupted during this, because part of my job is to work with people who have some crisis. So we'll work through that. You're very important to me, and we've had very, very little pushback on that, as long as it's integrated in throughout the entire organization, and that's the expectation. We do not routinely interrupt, well, we don't interrupt practitioners. They will interrupt us. So that part of it doesn't happen. The training, we require a full ATTC motivational interviewing training. We were fortunate that our ATTC offered that. It's a very extensive training. That in and of itself is a key component to the success of our staff. And then we're also, peerassist.org in Colorado offers an online training in SBIRT that our state has approved. But we also do on-site training. We have a trainer of trainers that is just starting to train all our SBIRT people here internally. So I think that's those two items.
Okay, thank you. What is the name of the smartphone app?
It's called A-Chess, and it's just like the game chess, C-H-E-S-S. If you Google A-Chess, you'll find the University of Madison, Wisconsin Center for Health Education System Studies, I believe. And you're welcome to contact me individually for further information on that if you want to as well. It's a consortium. You have to join the consortium, but we're really excited about that in the future.
Okay. Have you specifically tracked data related to SBIRT interventions with adolescents?
We have the data. It's not very big because we don't see very many adolescents. We are, as I said, I'm meeting shortly with the schools. We've been looking at a couple of schools that I've been able to find across the nation in North Carolina and Massachusetts who have, and I'm sure there are others, but have implemented SBIRT through the school nurses, and then another one has a school clinic that they're doing the craft screening instrument with. That's C-R-A-F-F-T. If you Google that, that's the pre-screen and screen that we use. But we don't have a wealth of data yet. The patient population, very few adolescents, but that's the area we're really, really working on now.
Okay. Here's a comment from someone. HJAHC in Trenton, New Jersey uses SBIRT. They started with annual pre-screens, then went to asking the SBIRT questions at every visit, but like you have since gone back to the annual pre-screens. Can you walk us through how SBIRT works in an acute setting? I'm interested in the process from the operational standpoint. I would like to implement SBIRT in my hospital.
It's a very good question. It's really two pieces for us. The universal screening occurs in the ED. The other SBIRT activity really, I guess I don't know if it is SBIRT activity in that on the med-surg floors, we are notified when there's a primary or secondary diagnosis of substance use disorder. And our staff joins the team and has the conversation. So we do use the pre-screen if necessary, but frankly, when someone has been admitted for detox or has a significant alcohol and drug problem, the SBIRT is really, we don't use it. Where we are beginning to use it is with those secondary diagnoses, and it is used in combination with motivational interviewing. I know that's pretty vague, but I guess if I could reframe it, it's in the ED, it's a fairly common SBIRT process of pre-screen, screen, and consult, brief intervention. On the med-surg, it's more focus on motivational interviewing and engagement in cooperation with the practitioner and going over the information of how the alcohol and drug use may be adversely impacting you.
Okay. And what indicators do you use for evaluation, and how do you collect the information?
That's a very, very good question. And, you know, honestly, I'm going to have to defer to, I'll have to answer that question for my quality improvement person because I'm not that much engaged in that process recently. So if that question, if they would forward that to me, I will get you the answer because I know we have a robust set of data that we're collecting. Sorry, I can't answer it in real time.
Okay, here's something different. Les, I was involved in the New Mexico DOH SBIRT project that started in rural primary care settings and then expanded into school clinics. I can put you in touch with the principals if you'd like. So I will forward that information to you after this webinar, Les, so you can contact this person.
Thank you very, very much. Can you do that in the next 5 minutes before I go? No, I'm just kidding. But I really will.
I promise, as soon as we're done.
That will be helpful.
And then after the pre-screen in the ED, where do follow-up BI/BT occur, and how many sessions are offered for ED patients?
The initial session occurs in space close to the ED, and then depending on, there is no limit to the sessions. As you saw, we get paid for up to 4 hours per year, but usually out of the ED, those sessions, the other brief interventions will occur either in the primary care setting or in our offices. That work in the ED is primarily just stabilization and the engagement piece. So there's usually only one really brief activity there, unless they're recidivists, and there could be more.
Okay. Okay, well, that's the end to our questions now. So I guess we can close this webinar. This is being recorded. And
Chris,
yes, yes.
I had asked to say something. This is Holly. I was waiting for the questions to come through.
Oh, thank you.
Hi, Les. Thank you for doing the webinar.
Hi, Holly.
And thank you all for being on the webinar today. Les, you mentioned a couple of things I just wanted to highlight for the group. You mentioned the motivational interviewing training with the ATTC.
Yes.
I just was wondering, like, can you characterize like how many hours of training that was? It was probably quite a lot.
It was extensive. I think it was almost 40 hours, and it provided mentorship over the course of the training. I think it was either 6 months, something like that. I'd have to check with Pat again, but it was very, very intensive and very good. I think there were maybe 2 or 3 days where they were on site, and then they received weekly mentoring calls during the course.
Right. So I just thank you, because I want to highlight that you guys were really fully committed, and you partnered to really invest in training your staff to, as you said, work in these settings and adapt to be part of the culture of those settings.
The training was really essential, and that matching the staff with the setting is key, as I said. You bet.
And then, Chris, I went ahead and showed my screen because I wanted to show the audience a resource that is on the ATTC website. So you'll see that right here. You could just Google attcnetwork.org. Chris, are you seeing this okay? I'll just look at the audience view. I'm assuming you guys are seeing the ATTC website. I can't.
Yes.
All right, thanks. Okay, and then once you're on there, you could go to distance education, and that will take you to healtheknowledge.org, which is just hosting a lot of our ATTC online courses. And there's a couple online courses that you guys might be interested in if you are new to this, or if you want to sort of maybe do a booster with your staff about working in a substance abuse settings. So I was going to scroll down to this course called Introduction to Primary Care Introduction to Primary Care for Substance Use Disorder Professionals. I wanted to highlight this one in particular because I saw that on our pools we had a lot of addictions providers who might be wanting to extend or replicate, or you're already doing a similar model to Les's group. And so this is a self-paced course that you could take, and it was developed by the ATTC and the SAMHSA HRSA Center for Integrated Health Solutions, as well as a bunch of other online courses. There's a Foundations of SBIRT. If you're starting from the very beginning, there is a Foundations of SBIRT course on here that would also help guide you and your staff to understanding SBIRT. And then I would just invite you to do as Les did and look for your regional center, ATTC, if you're not acquainted with them. If you're on this webinar because of your acquaintance with us as the National SBIRT ATTC, that you can find on our website who your region, where your state falls in the regions, and contact them and see if you guys could partner on some sort of training initiative. It might work out similar to how it did with Les. Okay, that was all I wanted to do, Chris. I don't know, Les, is there anything else that you wanted to?
I don't think so. I just appreciate the opportunity, and I'm looking forward to some additional conversations with people who are on, and I know I can learn a lot from what they're doing. So thanks for the opportunity.
Well, thank you, Les. And Chris, was there, I see there's things, comments. Is there any other questions from the group?
Somebody just asked about having the slides available. After the webinar today, about an hour after the webinar, you'll be getting an email with the link to the evaluation. And that's what we hope you will fill out then. I will send you a reminder about the link tomorrow morning, along with a certificate of attendance, the link to order NADAC or PA CEUs, and then also I will be sending you a link to the recorded webinar and also the PowerPoints. So you will get all that tomorrow morning. And with that, I don't see any other questions. So at this time, we will close out the webinar. Thank you all for attending, and we hope to see you again.